So good afternoon, everyone, and thank you for joining us for the second session of the 2021 Older Adults and Opioids webinar series hosted by the Finger Lakes Geriatric Education Center. We're a HRSA-funded geriatric workforce enhancement program at the University of Rochester. Our co-sponsors are the Western New York Rural Health Education Center and the Monroe County Department of Health. My name is Laura Robinson, and I am the program coordinator for the Finger Lakes Geriatric Education Center, and we are very glad you could join us today. So just a few housekeeping items before we begin. So there are two important buttons on your Zoom toolbar. Please use the chat button to type hello and introduce yourself with a name, job title, agency, and location. We have people from across the country joining us today. And the Q&A button will allow you to type in a question for the presenter. We ask that you use this button at any time during the presentation to ask a question so that the question doesn't get lost in the chat. And then we're going to address all the questions at the end of the session. So to introduce our sponsors, the FLGEC has been continuously funded by HRSA since 1999. We currently serve a 25-county area of the Finger Lakes region, but truly serve all of New York State through collaborations with many academic and community-based partners. Through educational initiatives targeting all healthcare providers and family caregivers, the goal of the Finger Lakes Geriatric Education Center is to transform clinical training environments by integrating geriatrics into primary care delivery systems, resulting in an age-friendly health system, as well as dementia-friendly communities. The Western New York Rural Area Health Education Center is a nonprofit organization headquartered in Warsaw, New York, serving 12 counties. And the R-AHEC's mission is to improve health and healthcare through education. The R-AHEC addresses the health needs of its communities by focusing on health workforce development, preceptor development and student housing, pipeline programming, and rural healthcare technology infrastructure development. And the Monroe County Department of Public Health has a long history of collaboration with the University of Rochester and the FLGEC. The Monroe County Department of Public Health provides direct public health services designed to protect the public from disease and environmental hazards, and community leadership to ensure improved health status of individuals, families, and the environment. Their services include education, preventative services, and enforcement of health codes and medical policies. So for right now, I would usually pull up my screen and show you our disclosure slides because we are approved for CME and social work educational credits for this session. But we're having some issues with Zoom, so I'm not going to pull up my screen just so Erin can keep her slides up. So today's session is called Unknotting Stigma with Erin Pownall Burns. The learning objectives are to conceptualize stigma in a tangible way, identify the impact of stigma on those who live with an addiction, and to list the ways that stigma has a negative impact on health outcomes. None of our planners or the presenter for today's session have any disclosed relevant personal or financial relationships with commercial interests pertaining to this activity. And following the presentation today, I will email you how to claim your CME or social work credits, along with an evaluation for the session. So our featured speaker today is Erin Pownall Burns. She is an enthusiastic trainer, recovery coach, and community advocate. She is a lifelong learner that owns and operates an innovative training company specializing in helping human service professionals take it to the next level. During the COVID-19 crisis, she has doubled her efforts to add value wherever and whenever possible. Her mission is simple: to come alongside others as they explore the task at hand, whatever that may be. And you can find more about Erin at www.erinpowellburns.com. So now I will turn the program over to Ms. Burns.
Thank you very much, Laura. So thank you everyone for introducing yourself in the chat. I see that we have Kathleen and Bernie, Teresa, Angela, Dr. Rick, and Carol. I was hoping that we could kind of get used to using the chat a little bit because I do want this to be pretty interactive. There's nothing worse than somebody just sitting in front of you in a Zoom room and talking at you for a whole hour. Hi, Sarah. So we're gonna try not to do that. So if you could just put in the chat, I want you to imagine that you were stranded on a desert island for a whole year and you had nothing but what was available there. It was probably raw, there was no salt at all. And you just got back to civilization, right? And this is like post-COVID, so all the restaurants are open and any food you can imagine is available to you. Will you just go ahead and put in the chat what you would eat for your first meal back in civilization? Oh, hi, Kate. Glad you're here. Ooh, tacos. All right, cool. Pizza. I've got a 3-year-old. He loves pizza. What else? Oh, barbecue ribs and brisket. Indian food. Bernie, I'm with you. Italian. Ooh, there's a lot of diversity here. Seafood. Pizza as well. Cool. Crab legs. Very refined. Ice cream totally counts as a first meal back to civilization. All right, thank you. Thank you all. Everything above. Okay, so just trying to see here what our objectives are. Oh, sorry, having some technical difficulties. There we go. Okay, so I want to kind of take a couple minutes to orientate ourselves to the problem, to the situation, and to opportunities, right? We're going to accept nuances and complexity. We will talk about stigma, and we're going to talk about why it matters. Like, stigma in and of itself isn't the whole picture. I will talk a little bit about my story. I'm a person in sustained recovery. And then I will include like a couple tips for what are some tangible, actionable things that we can do and integrate into our practices and into our way of being to help be a part of the solution. And then I want to spend a little bit of time talking about radical recovery support and what that looks like. There'll be opportunities for interaction throughout this presentation. And if you have a pressing question, please put it in the chat. And if I don't catch it, we will address it at the end. So I don't think that you guys were, I didn't think that you forgot about COVID-19. And the truth is, we don't really know how this is going to, we don't know the full picture, the full fallout of how this is going to impact people with substance use disorder or other mental health challenges inside of our population. We do know that this has been increased time of stress and isolation. We do know that the healthcare system itself was tested, limited, and adapted, really. And we do know that vulnerable populations were disproportionately impacted. And since we know these things, it really, the onus is on us to be innovating all of the time, in real time, for both the problems of today and also the problems of tomorrow. Over 81,000 drug overdose deaths occurred in the United States in the 12 months ending May 2020. This is the highest number of overdose deaths ever recorded in a 12-month period. And to give you kind of an idea, to conceptualize that better, that is 222 people a day. So this presentation is roughly an hour long, which means that in the time that we spend together, 9 people will die from an opioid-related poisoning. I do use that word poisoning purposefully, and we'll talk a little bit about that. 1 in 4 families in the US has a person with an opioid use disorder. And more Americans die of an opioid overdose every year than died in the entire Vietnam War. So I did use the word poisoning, and I do believe that that is true. So when we, sometimes you still hear the word heroin overdose, and that's usually inaccurate in today's society and landscape. So 37 of the 38 jurisdictions across the nation with available synthetic opioid data reported increases in synthetic opioid involved overdoses. 10 of those reported over a 98% increase in synthetic opioid involved deaths. So it's important to note that many overdose fatalities also include benzodiazepines and alcohol. So, so we should really be talking to people about that, you know, about how the use of opioids and other sedatives together increase the lethality and the dangers involved. I do want to say that people with opioid use disorder are not the only vulnerable group that's harmed by stigma or affected by this pandemic. 1 in 7 people in the US will face a problem with addiction as a whole. And, you know, alcohol kills many, many people. I think the last statistic I looked up was 88,000 a year. Nicotine as well. The reason why we're really talking about opioids is, well, 1, because of the trend, and 2, because of the possibility for immediate lethality, right, and death. Okay, so stigma. So the definition of stigma is a mark of shame or discredit. Laura, there's a poll. Would you be able to launch that? And would you guys just go ahead and fill that out? And it might seem a little unrelated, but I promise I'll tie it back in. So have you guys ever read The Scarlet Letter by Nathaniel Hawthorne? All right, so 70% of you guys are saying yes. 1 person can't remember. I feel you. Sometimes that happens to me too. Okay. All right, so thank you guys. All right, so let me just kind of give you a rundown. The main character's name is Hester, and she arrives in Salem without her husband, who's thought to be dead. She gets pregnant and she won't say who the father is. Because she's unmarried, the Puritan settlement brands her as an adulterer and mandates that she wear a red A on her chest or on whatever she's wearing. Some of them even want to kill her, okay? So again, this is when we think about a mark of discredit or shame, we can think in terms of that scarlet letter, that scarlet A, adulterer, okay? As an impact, or what happened after that, is her business fails. She's a seamstress and no one will hire her, right? Her husband resurfaces. He'd been abducted by Native Indians, but he doesn't disclose his relationship to her, okay? So essentially, she's now a single mom with no way to support herself and no social supports, living in a new place, okay? And I would argue that that's actually discrimination. So it's really not just stigma, it's the corresponding discrimination that causes tangible and devastating impacts on people's lives. For Hester, that was the socioeconomic stress and the lack of supports. Here's another way to look at it. So stigma is sort of overarching in this. You have stereotypes, right? So ideas. You have prejudice, right? Things that we believe to be true. And then discrimination has that action component behind it, right? And when we think about people with substance use disorder and supporting them through their recovery, I think really discrimination can look like action or it can look like inaction, right? It's both what we do and what we fail to do. So stigma is the root of the discrimination people with substance use disorder face while trying to get well. And we're going to talk a little bit about why that's important. And there's a bunch of different reasons. And some of them are kind of like softer reasons, right? So surrounding ideas of self-esteem and how people feel. And then other reasons are sort of more hard or analytical or financial reasons for this. So again, there's a tangible effect and a cost on lives. Some studies show that only 10% of people who hit criteria for substance use disorder seek treatment. And only 1/3 of those that do receive care that meets the minimum standards. So this is an imperfect analogy, but can you imagine taking your loved one to a health clinic for heart disease or cancer, where 2/3 of the people received substandard care, right? And that's the reality in a lot of situations. So I was looking up some of those kind of hard reasons why stigma and discrimination inside society and inside treatment industries, et cetera, matter. And I found this, and this was a little hard to wrap my head around. So it says the use of and addiction to alcohol, nicotine, and illicit drugs cost the nation more than $740 billion a year related to healthcare, crime, and lost productivity. And I also stretch you to think when you see that word crime, oftentimes we correlate substance use disorder with criminality. I think that there's a lot of evidence that shows that it's not necessarily that clean and dry. And a lot of the costs associated with crime are actually costs associated with criminal justice. And criminal justice is not always equitable. In fact, I think we're seeing more and more of how real reform is needed. I couldn't really think, I'm a middle income American, so I really could not conceptualize $740 billion. So I started to kind of poke around and see how the government was spending money, because they were the only ones that I could think of that that this information, that was spending billions of dollars that had some of this information available. So this is a federal spending pie chart from 2015. And what I noticed was really surprising. So the use of and addiction to substances costs the US more annually than the federal government spent on the following things in 2015: science, energy and environment, international affairs, housing and community, transportation, education, food and agriculture, and veterans benefits combined. I'm just going to take a moment and check the chat here. Let's see here. Rick, good question. That was from, so you said I mentioned minimum standards set by whom, on what basis. That was information that I got from the Surgeon General's report that I'm going to talk about next. Oops. Let's see here. Okay, so, all right. So Dr. Vivek Murthy, he was the Surgeon General from 2013 to 2017 under the Obama administration and partway into the Trump administration. He was recently in November nominated for the same position by the Biden administration. It's still to be announced, to my knowledge. So he published, or under his guidance, the first report from the US Surgeon General dedicated to substance addiction. He very strongly advocates for a change in the system. He focuses on removing the stigma. And this report says that for every dollar invested in viable treatment options for substance use disorders, saves $4 in health care costs and $7 in criminal justice costs. So another way to say that is for every dollar that is invested in viable treatment options, we save $11. He also, this report also mentions that genetics account for about half of a person's likelihood of becoming addicted. So one of the things, especially when I'm thinking about your population, that's really important is helping people talk about any past struggles they've had. So I'll tell you a personal story. I'm part of the recovery community, and there's this little old lady, and she was talking about her grandchildren. And she was so proud that her grandchildren had never seen her drink. And she leaned in and she was like, in fact, they don't even know that I've had problems with alcohol. And I was like, why? And she was like, well, I don't want them to know, And I was thinking, if she had had breast cancer, she certainly would have shared that with her granddaughters, right? As something to look out for, as something that pertains to their own health and well-being and life, right? And so absolutely having some of those conversations with our older clients, making sure that they are disseminating this information to their loved ones and people who are related to them as sort of a means of prevention. So we just spent some time talking about addiction, and that's important. Sorry, getting a little thirsty. But also, I think that we need to spend more time as a society talking about recovery, right? So SAMHSA defines recovery as a process of change through which people improve their health and wellness, live self-directed lives, and strive to reach their full potential. I'm gonna pop up in the chat, and I'm gonna ask you guys to do the same actually. Is there something that you notice about that definition that's missing, or something that you thought might have been there that's not there? Anything you noticed at all? And I'm just gonna pause a second and go ahead and stick that in the chat. Beth says there's nothing about maintaining sobriety, right? It doesn't say anything about sobriety. What else does it not say anything about? It implies that we all start with good health, right? Yeah. It doesn't mention any specific health change. It does recognize that this is sort of a quest, right? And it doesn't mention substances in here, right? It also doesn't mention abstinence, right? Just a process of change which people improve their health and wellness, live self-directed lives, and strive to reach their full potential. And I think that it's, Rick, I take your point. I think it's really important to recognize that also this is a definition that in some ways we can all identify with, whether or not we've had any problems with substance use disorder. So there are 4 major dimensions that support recovery. Health, right? So overcoming and managing symptoms that make and making informed healthy decisions and choices. I think this is a really important part, right? So making informed decisions and having that person do that. I was in a training the other day and this woman said, however, she said autonomy is an ethical value. And so really respecting the autonomy of our clients and patients. The other dimension is home, right? Having a stable and safe place to live, right? It's going to be really difficult to work on any, I mean, just think about working on any of the problems that you guys are facing in your personal lives, right? Because we all have some problems. And imagine trying to work on them without a safe, stable place to live, right? Purpose. So meaningful daily activities and having independence, income, and resources to participate in society. We live in a pay-to-play society. I don't know if you guys have ever tried to do anything with no money. It's really hard to be connected to any sort of activity when you don't have any resources. And community, so relationships and social networks that provide support, friendship, love, and hope. I do kind of want to note about the health, right? So these are 4 dimensions that support recovery. I oftentimes think that there's somewhat of a separation between detox and recovery, right? So if you're a provider, definitely urge you, if you're having somebody in that who's initially experiencing the road to recovery through detox, right? And through those withdrawal symptoms, to treat the symptoms of withdrawal as you would with any other disease. So I'm going to check the chat again because I think you guys are brilliant. Let's see here. Okay. Bernie, the definition reminds me of how we have tended to avoid directly addressing unpleasant topics like death, substance abuse, and sex. And also just the idea that we think that those topics are unpleasant, right? You know, death is sort of a taboo subject in our society, but it's not that way in other cultures. And it is something that we all have to walk through. Substance use, I believe that everybody really is on a spectrum of substance use. Sometimes it's problematic and sometimes it's not. Sometimes it becomes problematic and then it's walked back, right? And sex, I wouldn't name as an unpleasant topic, but sometimes it can be uncomfortable to talk about. Okay, so sometimes I go to a lot of webinars, and a lot of continuing education is really important to me. And I sometimes I'm sitting in these trainings and in these workshops, and I'm like, oh my gosh, that sounds nice. That sounds like a lot of pretty words that you're saying, but the reality of working in addiction and the reality of working with the people who suffer from it often feels like this for them and for me. You know, right now I work on an outreach team working with people who are chronically homeless or high definition chronically homeless in Monroe County, and it's hard, right? And I see people at their absolute worst every day, and I work with them for 6 months, and generally speaking, in those 6 months, they're pretty much still at their worst, right? There are occasional glimpses of hope, but a lot of times it feels like this. And so I wanted to share with you guys something called the Clinicians Illusion. So it's a bias that clinicians develop over time. And it's essentially a disbelief that people with serious mental health problems or substance use disorder ever get well. Because we tend to see people only when they're symptomatic, right? And not only that, but when we stop seeing people, we also have this bias that tends to assume that they're still symptomatic, that they're still really sick, right? So I'm gonna give you an example. Like if a physician, physicians have well child visits, right? Or maybe a physical every year. In the interim, your primary care doctor, right? Like let's say you went last September, right? From September to now, your primary care physician isn't like, oh man, you know, what's happening to Kathleen or what's happening to Teresa or Angela? I bet they're really sick, right? I bet they're not doing very well, and that's why I haven't seen them. Your primary care physician assumes, on the other hand, and in opposite, sort of to this clinician's illusion, that you're totally fine, and that's why they haven't seen you. So this is real, and this impacts the help that we give people. And it also impacts burnout and how we feel about the work that we do, right? So I have a couple tips for you guys, because I definitely want to make some of this actionable. So the number one way to combat this, I think, is to seek out stories of wellness and recovery, right? So if you work with people who have substance use disorder, figure out how to go to an open recovery meeting where you can hear someone's story of how they got better and what their life is like now. Let's see here. Oh, okay. So this was a fun one. This is my brain, guys. And I have some issues with this slide. I did get it off of www.drugabuse.gov. I'm not a real fan of the word abuse when it comes to talking about people with substance use disorder or how we use substances. But anyway, so the government's slow to change. So this is treatment and time enable people to counteract addiction's disruptive effects on their brain and behavior and regain control of their lives. So this is a healthy person you see on one side. In the middle, you see a person who used to use math who has 1 month away from math. And then on the other side, you see 14 months away from math. You can see how the brain heals, right? And so this is literally my brain. When I stopped doing math, I had to take a month off of work. I almost said a year. That would have been nice. So yeah, I had to take a whole month off of work. I slept and ate for a whole month. And I also have to say that I acknowledge that my privilege in doing so, right? Not everybody can just take a month off of work. I happened to have no kids at the time, and I was living out west, and I was in a sales position, and I was making really good money, and my bosses really liked me and understood that I needed some time to just take care of myself. So I don't know, just kind of put in your pocket that people do recover all the time. It's a commonplace miracle, right? So just kind of remember that. Okay, so tip number 2, don't look at every behavior as related or attributable to substance use disorder or mental health diagnosis. This sort of attitude or attribution kind of strips people of their humanness just a little bit. And I'm going to give you an example. I'm late sometimes. I tend to be late, right? It is not because I have started using drugs again. Sometimes I have a hard time regulating my emotions, especially when I'm super passionate about something or I see something that's unjust. That is not because you know, I used drugs and alcohol for an entire decade and developmentally I'm still a teenager. It is just that sometimes I get angry, right? And that the world is unfair and I have a hard time mediating that sometimes, just like everybody else, right? And language. So this is another tip, and we're going to kind of talk a little bit more about this. And I am sure you guys are all familiar with it. But what are some of the words that we use for people who live with substance use disorder or mental health challenges? Can you guys throw that up in the chat? I'm going to find the chat again. There we go. So just what are some words that you've heard people use for people who have substance use disorder? Drug seeker. What else? Keep them coming. Addict, right? User, junkie, user. Right. Laura, would you throw up the poll? The second poll. Have you ever heard or used the term substance abuser in a work setting? Right, right. Okay. So about 63% of us yes, and 40% of us no. Right. And I think that again, this term, right, it kind of it's not very inspiring in some ways, right? So, and also it is naming the person by the worst part of themselves. So I want you to imagine the thing that you feel the most shame for in your entire life, right? I don't know what that is for you, right? Maybe it's cheating on a husband. Maybe it's having a substance use disorder and having problems with it. Maybe it's not being the kind of parent you want to be. Maybe it's, you know, whatever it is for you, right? And then think about somebody just calling you that, right? Especially somebody who's supposed to be helping you. So it really doesn't frame things very well, okay? So it impacts the help that we get, right? As for me, right? Because I identify as somebody who is in recovery. It also impacts the help that we give. And I'm going to give you an example of that. So let's say you're working in a clinic and there's a difficult client, and that difficult client is me, right? And one of your peers is like, oh my gosh, somebody's got to go check on that crackhead who lives on Chapin, on that corner in that trashy apartment, with the kid, you know what I'm talking about? Can you go check on her, right? That is going to be a completely different conversation, and you're going to interact completely differently with that person than if your colleague says to you, hey, that single mom that lives on Chapin, she's having a really hard time and she's reporting that she's really struggling with crack cocaine use. Do you think that you can go check up on her? I know that she's got a daughter there, and she might need some resources and linkages to food and just some support in general, right? So those are going to be two different conversations, and that is actually going to impact the kind of help that person gets. So I definitely encourage you to embrace person-first language, to be recovery oriented, and to also recognize that we in the treatment industry, right, are not immune from the inconsistencies that society feels for people who live with substance use disorder. So let's see here. And oftentimes it sometimes feels like we throw money at the problem, right? But not too much money. And we're most comfortable with punishing treatment techniques. We're not that far off, and we're not that far removed from, the hot seat. And sometimes it's hard to really believe that people can get well. And then at the same time, we're frustrated that they're not, right? So language has the power to humanize or objectify, engender compassion or fear and hatred, to motivate or deflate, or to comfort or wound, right? And so we get to decide what we want our language to do. And it's a really easy adjustment. It doesn't cost us anything. Yeah, so Bernie says those points about language and attitude are very important. Adding another wound to whatever that person has already sustained, even if never spoken aloud, it affects and how we'll act, right? And think and feel about the person. Absolutely, absolutely. And that comes off in our body language, in the way that we answer the phone. That comes off in every interaction. So we're going to talk a little bit about harm reduction, and this will be another little tip. Can you launch the next poll, Laura? We practiced harm reduction today. Okay, so we're about, it's dancing for me. So about 57% of you say yes, and 43% of you say no. 47%. Okay, so we're about half and half. Okay, so harm reduction is a set of practical strategies and ideas aimed at reducing the negative consequences of X, Y, or Z. So I really hope that everybody practiced harm reduction in some way today, right? So I'm going to give you an example of harm reduction. When you went outside or when you went to work, did you guys wear a mask? So wearing a mask is a harm reduction tactic. It's used to mediate the dangers of interacting with folks during a pandemic, right? If you drove to work today, I guess one of my questions is, did you wear a seatbelt? Right, that is another harm reduction measure. And I want to point out something super important. Seatbelts do not aim to end car crashes or to make people stop driving cars. That is not the goal of seatbelts. Seatbelts seek to mediate the potential harm that comes from doing so, that comes from driving in a car, right? So we're trying to reduce the harm. I assure you that if you have clients, if you know people who are out there actively using drugs, they have done a risk-reward assessment, and they have in that assessment, they have decided that using drugs, the reward of doing so is worth the risks of doing so. Just because you or I wouldn't make the same assessment right now doesn't mean that they didn't do it. Okay, so part of our work should be helping people to stay alive until that risk reward assessment changes for them. Okay, so a lot of times harm reduction is controversial because we think of it in terms of safe injection sites or needle exchanges and Narcan, and all of those things are really important, but sometimes it just looks like a conversation. Sometimes to circle back to the beginning, sometimes it looks like a conversation about, taking your opioids and then also drinking or taking benzodiazepines with it and other sedatives. How can you adjust those behaviors? It might look like if you have somebody who's actively using, talking about how they're using. Are they using alone, right? What could they do to make that use safer, right? Because we cannot help people recover who are dead. And so that's the kind of number one thing. Let's see here. So again, let's imagine treatment that really takes into account those 4 dimensions that SAMHSA says support recovery. So imagine a treatment program that instead of focusing on the pathology or the problem, sought to practically support these dimensions. This might feel really countercultural sometimes, right? And I might suggest that if it does feel countercultural and you're coming up against a wall inside yourself, which happens for me all the time, by the way, I'm like, oh, but I thought, that's okay. And that might actually be an indication that in some way you're opening up and heading in a direction that might be more effective and more helpful. So speaking about countercultural, I want to introduce you to Professor Carl Hart. He has a PhD in neuroscience and studies drug use at Columbia University. And he challenges us, he really challenges us to question many of our assumptions about drugs. He talks about drug use as a symptom, not a cause of societal ills. And says that drug policy has caused more harm and disproportionately to Black and Brown communities. So I wanted to interject a kind of personal story before we go back to Professor Carl Hart and some of the work that he's done, which I find really inspiring. And I was thinking about this presentation last night, and I looked over in my bookshelf behind me, and I found this book. And this book is Power Questions, a book of power questions. And it was given to me by one of the people that I bought drugs from. And I think that it might in some way have been the small seed of the path that I'm on now, because I am just fascinated by, asking good questions, as anyone who's interested in social work is. So just a tiny story about that is, I used to buy drugs from this guy who called himself North Star. And he was put in the foster system at a young age, moved to 9 different schools, did not have a GED or high school. He dropped out. When he got out of foster care, he ended up taking care of his biological mom, who had a lot of mental health problems. He also cared for five children, 2 of which were his, and then 3 of which were stepchildren from a previous relationship when I met him. Like, he wasn't even with their mother, but he also provided for them. And he had a record from being an adolescent, and he had no diploma, and he worked at the local hospital as a janitor, and he also sold crack cocaine. He did not do drugs. For him, it was a matter of economics. He needed to make a viable living, and it was the only thing that he felt like, or he knew how to do, that would, yield the kind of economic security that he sought to take care of his mother and those 5 kids. Right now, I am in front of you doing a webinar, and this is a direct result of the privilege that I carry as a white woman in the United States. And he is doing 10 years in federal prison, or excuse me, in state prison for selling crack. And his brother, who also sold drugs with him, his name is Johnny. He's the one who gave me this book. He's dead. He died the summer before last. He worked at a local waste management place, and he would bike 15 miles to work every day and 15 miles back. And last summer, or the summer before last, excuse me, it was super hot, and he biked there and biked home, and he complained of abdominal pain, and they found him passed away. And I just think about, I think about some of the stories that we tell ourselves about people who sell drugs, and, those t-shirts that say, kill your local heroin dealer. And I think about how we have completely missed the truth in that narrative. I've never told that story, but I thought it was important. So let's go back to Carl Hart, and I want to talk a little bit about the experiment that he did. So as a person who used to do drugs, I really don't like images of drugs because I feel like my brain is forever changed. I'm going to check the chat here for a second. Yep. So this is a molecule of methamphetamines, and then on the other side there's a coca leaf, which is completely changed and processed to make cocaine. Okay, so the experiment that he did was he advertised $950 in the local newspaper for smoking pharmaceutical grade crack. The deal was that you had to live in a hospital ward for a few weeks during the experiment, and every day in the morning they would blindfold you so you wouldn't see how big the hit was, and they would give you a hit of crack cocaine. And it would be of various amounts, okay? And that was every morning. Then throughout the day, they would offer you opportunities to smoke either the same amount of crack cocaine as the first dose, or you could opt for an alternative. And the alternative was $5 cash or a $5 voucher for some sort of merchandise store. And you would get that $5 at the end of the experiment. And what they found was that if the crack dose was big, or the crack hit was big, the person typically chose that, right? But if the crack hit was small, they were much more likely to choose the alternative, the $5, right? Which is a completely rational decision. And that kind of tipped the caricature that society has about people who smoke crack cocaine or people who use drugs on its head, right? We're sort of portrayed as a junkie or a fiend, right? Those words that or an addict, right? That's what we are, right? So that was really interesting. And he also did this same experiment with meth as meth gained in popularity and kind of moved across the nation. And he found similar rational decisions being made by people who hit that criteria for substance use disorder and who were offered drugs, right? But the really interesting part is that when the alternative was made more attractive, like increased to $20, then everyone in both the crack and meth experiment chose the $20, even though they didn't get the $20 right then. It was at the end of the experiment, the 2 weeks. And so this rational decision-making runs really opposite of our sort of mentality about those who use drugs. So the kind of core of that is that attractive alternatives help people shift behavior. And he gave this interview that was published in the American Psychological Association in 2014. And I just want to read it to you. He said, and I quote, "If you present people who meet criteria for addiction with a choice between the drug and an attractive alternative, you can shift the drug-taking behaviors if the alternative is attractive enough. People will choose the alternative reward instead of the drug. This has been shown in lab animals, in work we've done with crack cocaine users, and work we've done with methamphetamine users. It's one of the most effective treatments we have, but it gets no or limited attention, in part because it's not sexy. You don't have a brain imaging picture to show people, and so people are not interested. And to me, that's a shame. It's probably one of the most powerful technologies we have, and people are ignoring it. So the question I kind of have is, what if we opened doors instead of closed them for people who have substance use disorder? What if we moved from fixing what is wrong to providing alternatives and opportunities? These ideas are not directly related to my story, but there are some parallels. So when I first entered recovery, I think I had about 3 weeks where I was doing better, maybe a month, and I decided that I needed to go to school. And, you know, a lot of folks were like, no, you should not do that. You're going to overwhelm yourself. You can't possibly. And I'm so glad that I did, right? Because it was a really important part of my recovery. The other kind of parallel that I'll make is I voluntarily went into an outpatient, was like, I need some help. And they're like, okay, all right, you know, we take your insurance, et cetera. This is what your treatment plan is going to look like. You're going to pee in this cup. You're going to do this, this, and this. And I was like, wait a second, like I'm feeling really bad about myself. And I am 100% sure that peeing in a cup in front of somebody is not going to help that. And I don't want to do it. And they almost didn't accept me into their program because I refused that part of their treatment plan because it wasn't going to work for me, and I knew that. They finally compromised and let me test my own urine, which I didn't stay there very long. I didn't find it supportive, and I really think that I would have benefited from something, because it was really, really hard. That was really hard. And at that point I was a single mom as well. So this kind of brings me to my last slide before questions. And I'm going to check the chat really quick. Okay. And then I'll open it up for questions, because I really, you know, do want to address anything. So I am a little bit of a busybody, and I really like creating opportunities for other people. So I have started a micro business called Sugar and Snow. It's a pilot program. It's only run in the summer. And it's specifically designed to help people who are in early recovery to be employed and have a sense of purpose and be able to work on some vocational things while also building their self-esteem. So I sent out a survey to people who are currently in outpatient treatment and or treatment court, and said, hey, how much time are you guys spending on these things? What does your schedule look like? What would you need to be employed? And also, do you want to be employed? Right. And it was really funny because a lot of them, on the survey, I was like, you know, do you want to work? Right. And the options were hell yes, heck no, or I don't know. And almost universally, everybody was like, hell yes, I want to work. Right. And then figuring out what they would need to make that work. Right. So are you receiving social welfare benefits that, you know, if you make too much money, they're going to not be able to support you. And then that's going to cause other problems. So how can we design something that really will work for you? And how can they be a part of that? Right. Because I don't know what's best for people. They do. It's my job to kind of help them figure that out, come alongside them and open doors. So what they said they needed was flexible, short shifts. They needed recovery, friendly leadership, right? They needed peer support, transportation and ongoing training, clear expectations, what you can do, what you can't do, and also to be a part of something. And so I've designed this to do that. Our real product is people, right? And the vehicle for that just happens to be snow cones. So I'm super excited about that. We should be launching in May. And I'm going to open it up for questions for the last 5 minutes. And
Erin, thank you. Oh, thank you so much. Go ahead.
No, I just, sources are on the next slide as well.
So I invite everyone, please use the Q&A feature to ask some questions of Erin. We do have about 5 minutes left, so we have plenty of time for questions. And I do appreciate you sharing yourself and your story with us, Erin. I know that while we're waiting for folks to type in the chat, we did have one question that came in during registration, which was, what are we doing during COVID to help older adults who have opioid substance abuse issues?
That is a beautiful question. So it really depends. I would say best practice is absolutely MAT. So one of the things, I just went to this great training, and it was really interesting for me to see one of the statistics that was rolled out, and I can get you that information if you need, but was 90% of people with an opioid use disorder who go to some sort of detox or rehab, if they leave and are not on MAT, 90% will have a reoccurrence, right? And so this is much, much different than statistics involved with people who have alcohol use disorder. So that number is like 40 to 50%, which is really, really different than 90%. So this idea that, not that we should be, it's not a one size fits all, everybody should be, on subs or, or MAT if they say that's really not what they want, but having this conversation about it. And it's effective for people of, I don't, above, it's effective for the older population as well. There. Any tips on helping seniors? So yes, Matt, and also, seniors are having a really hard time just engaging in the technology in the same way that we are, right? So how are we getting really flexible and also doing that in an ethical way, right? So does your organization have certified recovery peer advocates that can go out that are mobile? Can we get flexible about that? Can we, as and the weather's really bad, right? So how can we utilize harm reduction, both as far as being in the middle of a pandemic and also mediating the harm that opioids cause in the lives of older populations as well?
So I'm not seeing any other questions yet. I don't know if people are still typing, so yes, take a drink. I know we had a lot of good comments in the chat, so thank you so much. People like your perspective on individuals who deal with drugs, and that's been very powerful. They like your business idea. And definitely, yes, we will have access to this recording afterwards. So the R-AHEC is going to host this on their YouTube channel. So we'll get those ready for you. And I don't see anything else.
I will just put my email address if anybody wants to email me.
But I appreciated this, especially with the fact that ageism is still very prevalent in our society. So just it's more, I think, more difficult for seniors who already have that ism on top of perhaps the opioid or substance use disorder to deal with both of those things, as well as kind of being marginalized by society as having value. So can you speak to any of that?
Yeah, absolutely. And the other thing, I'm sorry, something just kind of came to mind as you were speaking, and it was really having those conversations about medications, and especially since, that population is much more likely to be on a variety of medications, including benzodiazepines. So making sure that you're having that conversation. And can you restate your question, because I missed it? I was thinking of that.
No, it's okay. I was just thinking about the intersectionality of just being an older adult and having the substance use disorder, and possibly, not having as many resources, whether they are economic versus if you live in a rural area, not having transportation, not having community resources, just the intersectionality of all of those isms and how that might impact, in particular, older adults.
I think it's really tough, and like recognizing that, you know, when they're talking to you about that, right? Instead of like blowing through it and just like wanting to give them a resource right away, you're just being like, this is tough. This is really hard, right? You're feeling really isolated, and recognizing that and not sugarcoating it. I was working with someone the other day and she was complaining about her therapist. She's like, he's just so upbeat all the time. And that is not my experience right now, you know? And so making sure that we're recognizing that, and then getting creative and really stretching the system, right? How can we radically help this person? You know, does this person need an Uber to go somewhere? Is that in her budget? Can we advocate for that? Like, how do we make that happen, right? Thank you, Beth.
Yes, and then Lynette asked, are there any resources available in Erie County via telehealth?
I don't know that specifically.
And I'm wondering if Christine, who's still with us, if Christine knows about any in Erie County. There's Christine. If that covers your catchment.
I am sorry, I don't know. I can see if some of my colleagues have more Erie County relationship area and get that info out.
There is an agency called In His Name Outreach. It is a faith-based organization, and I think that they would probably do some telehealth. They also do sliding scales, but they don't take insurance. But if they cannot help, I'm sure that they're more aware. Dr. Donna is the executive director, and she's amazing.
If you could send me that link, I can put it in an email to all the participants after the session. That would be very helpful. Okay, and I do want to be aware of everyone's time. It is a little bit after 1, so we went a couple minutes over. So Beth, thank you so much for sharing, or Beth, Erin, thank you so much. It's Beth that said goodbye. Thank you so much for sharing your story and your resources and just your wisdom and your knowledge about this area. We truly appreciate it. And Christine, thank you for being a co-host, and everyone for being with us today. We realized you have a lot of options out there for education and for spending your day, and this was just another Zoom meeting for you, but we truly appreciate your attendance here with us today. So thank you and have a wonderful weekend, and we'll see you in a couple weeks for our next session of the opioid webinar series. Have a great weekend, everyone.
Thanks, Erin.
Right. Thank you, Dr. Rick. See you later.